So the second part is that what starts as a voluntary conscious behavior, taking a drink, becomes unconscious and automatic.
Welcome everybody, it's Katie with Ria Health, and today I'm here with Dr. Mark Willenbring. Dr. Willenbring is an addiction psychiatrist and researcher who has been recognized internationally for his work in pioneering how we treat alcohol addiction, and particularly evidence-based tools to treat alcohol addiction. And so, as I was just telling you, I've been super fascinated by your career in this realm, and so I'm so excited to be chatting with you today and just want to thank you for speaking with me.
Thank you, Katie.
Yeah.
Nice to be here.
So I want to just begin with a bit about your background in the realm of studying effective treatments for alcohol dependence. Can you give us a snapshot of your 30-plus year career in this field?
Just about 40 now.
Just about 40, okay.
So, what's interesting about my career is that I've been pursuing the same thing right from the get-go. One of my first studies that I ever did was at the VA hospital here in Minneapolis, and I developed a treatment program for people who had severe alcohol-related medical illnesses who were still drinking, and we used a chronic case management approach, like you would with any chronic illness, right? And and it took about 3 years to get the model working. And then I did a quasi-experimental study where because we just didn't have room for everybody who was referred. So we looked at people who were referred during the same period of time as the sample we looked at. And we looked at them 2 years later. And that's the nice thing about the VA is you have such great records. And and it turns out that, this is a very sick population, I'll say that to begin with. And so the 2-year mortality rate for people just going to medical clinic, referred to medical clinic after they left the hospital, was 30%. That's a very, very high mortality rate. And we were able to drop that to 20%, which is almost unheard of in healthcare, maybe in cancer, but even there it would be hailed as a huge breakthrough. So we then applied for funding, and we got funding. We did a controlled trial, and we found exactly the same thing. We were able to reduce mortality and reduce morbidity. We also reduced drinking significantly more than the control group. But the biggest thing was that we cut the death rate by 1/3. That's a lot. That's a big effect. So that was back in like the late 80s.
Wow.
And so since that time, as I sort of grew in my expertise, and also because I've always done everything all at once, which is, I was running a treatment program, I was a clinician in the program, I was teaching, and I was doing research all at the same time. So eventually I ended up becoming more and more interested in implementation of evidence-based practices.
Instead of just researching them.
Yeah. Instead of just developing them or researching different treatment methods, I was looking at how they actually get implemented in real life. And that continues to be a huge, huge problem. I mean, no more than in addiction, no more than anywhere else. Or no less than anywhere else. And in fact, within addiction, the penetration of evidence-based practice is almost nil. I mean, even now. So, well, right now I run a clinic that's called Altyr, A-L-L-T-Y-R. Doesn't mean anything, by the way. It's not an acronym. It's a mythical island off the coast of Russia.
That's right. I read that. I love the name.
Yeah, it's a great name, but we used it because there was no one else in the space who had that name. It starts with aid, which doesn't hurt. It kind of rolls off the tongue, and that my wife, who's kind of a branding expert, said that's how people find names for new companies. So when people ask me what it's what does it stand for? I asked him, well, what does McDonald's stand for?
Yeah.
Right?
Yeah.
What does Folgers stand for? Doesn't mean anything. Right? It stands for coffee because it was a successful product. Anyway, so I founded Altair Clinic 6 years ago now. Yeah, so I retired from the federal government when I was 60, 10 years ago. And then I lost my mind and became an entrepreneur. I've been in the government my whole life. And so it was a steep learning curve for me. And I also worked at a hospital, a private hospital here in St. Paul called United Hospital. And worked there full time for 3 years or so. And while we were putting the corporate structure together for Altair and really developing the ideas there, it took that long. And but I'll tell you, it was really an eye-opener to go from an academic medical center to NIH, this mecca of research, and then a private run hospital with fairly little teaching. So it's not an academic hospital. And I was shocked by the distance between what the researchers were thinking was going on and were doing and what was actually happening in the field.
What?
It was almost a total disconnect. It was really amazing. And also how uninterested people were that I had this background. I came in there sort of full of myself and, introduced myself to some of the house staff and so forth. And they didn't really care where I came from. It was just like, how can you help me get this patient out of the hospital?
Oh my gosh.
It was great.
You're like,
Yeah, it was really a good education in that. And I also learned a lot about insurance companies and how the fee-for-service model inhibits innovation tremendously. It just is just terrible. Anyway, so then I started the clinic here 6 years ago, and I've been full-time here now for about 5 years. And my staff has grown from myself alone to now I've got me, and then I've got 4 therapists and some administrative staff and a nurse. So we treat about 450 patients a month.
wow. Wow.
Anyway, and now we've actually want to go to California. We've actually got to kind of establish a toehold there and hope to develop that clinic as time goes on. So when I retired from the federal government, I've been giving a talk for the previous 3 years called Alcoholism Isn't What It Used to Be.
Mm-hmm.
Okay. And what I meant by that was that there was this pioneering research that was done by NIH, by actually NIAAA, the National Institute on Alcohol Abuse and Alcoholism, which I was a division director there. And so I was all over the country. I was all over the world actually giving the same talk. And what they found they did an epidemiological study, which means studying the natural history of things. But this was unprecedented in its scope. 43,000 people in the first sample, a national probability sample, oversampled for women and minorities. And they followed the same cohort for 3 different iterations. And then they changed to a new cohort, which is an interesting story in itself. But so we were able to follow people. And by that time, there were 2 waves. And so they were 3 years apart. So we had wave 1, and then we had the same people interviewed 3 years later. So it could look at predictors of relapse, predictors of development, sort of the natural history of things. And that study alone has completely changed how we think about addiction. It's just taken all the myths of rehab, that I call them, and just turned them on their heads.
Wow.
On their head. And the whole idea that substance use disorders are universally progressive, false. The idea that there's such a thing as cross addiction if you're recovering from the first substance, false.
False?
False. There's no such thing as an addictive personality.
What? You're blowing my mind right now.
No, that's completely false. There's a tremendous heterogeneity in the alcohol-dependent population. More than 17 million people, adults age 18 and over in the US, meet diagnostic criteria for an alcohol use disorder in any given year. More than 17 million people. How many of those people get treatment, or what we call treatment?
I mean, the stat I've seen is 1 in 10.
Yeah, but it's about 2 million
Okay.
out of 17. That's about right. About 1 in 8, 1 in 10 will have some sort of brush with the rehab system.
Mm.
So first of all, and by the way, one of the things I knew going into this was that we were only seeing a very small fraction of the people with a substance use disorder in rehab, because I used to run a rehab program. But I changed it a lot to where it was evidence-based. But whatever. The point being is that, well, who are these other 15 million people, and what do they look like? Well, guess what? It turns out that they're nowhere near as severe as the people in rehab. They have far, far less comorbidities. They have a lot more social capital. And almost all of them have a single episode that lasts a few years, and then it goes away and it never comes back.
Wow.
Right. Wow. And it's not progressive. That's another, I mean, that really blew me away. Not at all progressive. And this idea that the family's sick, that's all bunk.
Wow.
No, it's all bunk. Enabling is complete bullshit.
Wow.
Yeah, exactly. All this huge money machine, and that's what
Which
it
is
is.
the rehab industry.
The rehab industry. So, that just, it's all wrong. And so that's why people don't go. Because, so the biggest reason that people say they don't go is, I'm not bad enough yet.
Mm-hmm.
Well, what that really means is I'm not bad enough to go to rehab yet. You take 30 days off of work, go away someplace, right?
Mm-hmm.
Pay $40,000.
Mm-hmm.
What?
Mm-hmm.
And the thing is that rehab just doesn't work at all.
It's not based in evidence, right?
No, it's not. No, it's based in ideology, not based in evidence at all. Not only that, but rehab is actually shifted. It was never meant to do anything in particular, other than to be an introduction to AA.
Really?
Yeah. So I knew two of the founding fathers of the Minnesota model, which is a 12-step based treatment model.
Yeah.
So how did they come up with a 28-day period of time? Well, I mean, so one of the, Dan Anderson, who's one of the founding fathers, was one of the founding fathers, and he's got a good sense of humor. He says, well, so what we did, we sat down and we thought about all the lectures people needed to hear about alcoholism, and it took about 28 days to give them.
Oh my God.
It was so funny, but it's not quite true. But here's how it actually started. The first week was attention to the body. So people go through withdrawal, they would get medically worked up, they get 3 hots in a cot, they get their cobwebs out, and that sort of thing. Weeks 2 and 3 were oriented towards educating people about the disease model of alcohol dependence, okay? And giving them an introduction to AA. So they would go out to AA meetings a couple times a week. And the 4th week was discharge planning. That's all it was. Now, they knew that this is a chronic illness. They all knew this. But their thought of it at the time, it was no science. At the time, they thought the work was in AA. So it had to take place over a period of time, and it took quite some time often to achieve stable recovery. Some people just didn't at all, and they died. And they all knew this. But somewhere along, so that's how it was really meant It was meant to sort of introduce people to AAs, to stabilize them, and then introduce them to AA. Why would you ever need that more than once?
Yeah.
You wouldn't. And people don't.
How did we get here?
But I don't know. This is a mystery to me, and I haven't had a chance, I haven't had time to look into it yet. But somehow it morphed into the idea that something magical happened in rehab. The clouds parted, the light shone out, there was a choir singing, oh, and it was like, you just have a spiritual awakening in rehab? No, you don't have a spiritual awakening. That takes years in AA. So somehow it morphed from an introduction to AA to basically some amalgam of something or other. Almost all of it done very poorly with really low-paid, low-trained people. There are like 13 states where you don't even need a GED to become an alcohol or addiction counselor.
Wow.
Yeah. So, some states like Minnesota now at least require a bachelor's degree. Wow. Can you name one other profession that lets someone make independent decisions all on their own with only a bachelor's degree? You can't do it with a bachelor's in social work. You can't do it with a bachelor's in psychology. You can't do it as a nurse. You're really dependent. And so in other professions, a master's degree is required for independent practice.
Mm-hmm.
But not in this field.
Mm-hmm.
So, so that's kind of an interesting twist on rehab. AA by itself, by the way, AA is, so I often tell this story to women in particular, but who come and see me who just like go, yeah, it made me feel horrible about myself.
Yeah.
And, say, well, most women don't need to be told they're powerless. That's usually not their issue. They usually need to be helped to be assertive. That's really their issue. And as well as the PTSD they all have because of sexual abuse and so forth. But so AA was founded by middle-aged Protestant white sociopathic men.
Sociopathic men.
Sociopathic men. These were men who had been jerks long before they became alcoholic, and they were jerks after they sobered up. The old joke goes, what do you get when you sober up? A drunken horse thief. A sober horse thief. So that's one of the reasons we have all these scandals going on, because you have a bunch of sociopaths running programs.
Not based in evidence.
No, they don't care. They don't really care about that. They're just in it for the money.
So who is AA and rehab for, or is it for anybody? Is it so archaic?
Well, I'll get to that. Yeah.
Okay.
So what they did was they basically developed a character development program for people who didn't really have a good character. So they didn't have a conscience. So the group became their conscience. Their higher power as they came to know them, whatever that is. And they were narcissistic, so it's kind of an anti-narcissism program. And if you look at the 12 steps, it's a character building program. You look at who people you've harmed, you confess your sins, you make a resolution to make amends and to be a good citizen. That's all very important in AA. So for that group of people, it's a wonderful program. But if you're not like that, it's not at all a wonderful program. But the thing about AA is, really, it's a small minority of people who affiliate long-term.
Mm-hmm.
A lot of people will affiliate for a few months. They'll learn quite a lot, but then they'll drop out. But they may still use some of the techniques and skills that they learn. But the thing is that it's primarily for people with really severe dependence. people whose lives have been blown to pieces by drinking. These are people who, if they actually, their dependence is so severe that if they pick up one drink, they don't know if they're going to die from it or not, because they don't have any control over it. I mean, I knew a guy, actually I had a patient who he worked all over the world. He was a very highly sought after machinist. I mean, really delicate machinery, machining. And he would work hard at a job for 6 months, 9 months, and then he'd go on a spree. And he'd blow all his money. But the thing, and he wouldn't remember most of it. He'd be in Vegas. He'd be, having a train of prostitutes coming through. He'd be gambling away his money. It was just amazing to me. But the thing is that he had no control once he started drinking. No control at all. So anyway, so AA is so people ask me, does AA work? What I always say is it works for the people it works for. It's as simple as that. It can't be studied in a rigorous way. And if you're not naturally inclined to affiliate, you're not going to. It's like sending an atheist to church. What good is that? Right? I mean, actually more people, my guess is, get well through organized religion than through AA. It's just that AA is a single entity and all these other religions are multiple. Now, this has also changed over time as we have become more secular. So that's another dynamic I'll get into in a minute. So that's those are some stories about AA. And AA is fine if you like it.
Yeah, exactly.
And actually there's really two kinds of AA members. One is a group who just goes for what's called the fellowship. They don't really they don't drink the Kool-Aid, they don't do the step work, but they really like being with a group of people who understand them and who they understand. And then there's the really small core of true believers. And they become major sponsors and they head up the organizations that are part of the skeleton of AA. So it really functions like a church. There's the people who go for the high holy holidays, right? And there's people who try to go, once a week or so. If they miss one, not a big deal. And then there's people who go several times a week, who it becomes the center of their lives. They're on the committees. They're teaching in the schools. They're doing all these different things. And they really keep the institution going and keep it together. It's a small group of people, but they're very important to the organization. That's how AA is structured. At any rate, so so moving ahead here. So when I started at the VA, the program there was an absolutely traditional 12-step program. And and then finally the founder, who was the founder of the Minnesota model, died, or he didn't die, he retired. And I was put in charge, and that was like the devil being put in charge of a church. I mean, people were really unhappy with that. But I changed it. It took 5 years.
To change it to an evidence-based model from the Minnesota model?
Yeah, much more so. And then, so to move ahead here to more to the present. So I started Altair Clinic about 6 years ago. Took us about 3 years to develop the model. That's what it does. You can't develop a new model in less than 3 years. It just doesn't happen. So it took us 3 years, and together we came up with a model that works, and works very well now. And we know who's going to come through the door. We know what they're going to want. We know how to give it to them. We've got a program for families that we know works, built on evidence as well, and so forth. So, and in terms of outside community support groups, we're fine with whatever people want to do. Some people go to AA, some people go to Smart Recovery, others don't, go to church, others don't go anywhere. They'll develop a few friends who understand, but that's that. So we were, and now we've been shopping it around. Now is a time for spread. And spread is a difficult model, as you probably know.
What do you mean by spread?
We want to spread the model around the country.
Mm-hmm.
Okay. Now, if you have just a digital app, spread is relatively easy. You can scale up quickly. But if you also have, face-to-face on-the-ground practitioners who see people face-to-face, or by telehealth, that takes a lot longer to develop. Anyway, and I'm working with another company now that is an interesting concept, and it offers us an opportunity to spread fairly rapidly, I think. But anyway, so how do we work? What does evidence-based practice look like? Well, it looks like every other evidence-based. It looks like every other medical specialty. So if you think about the continuum of care, we've been trying to treat a chronic illness with a single model of intensive outpatient or inpatient treatment. There's nothing on the other side.
Mm-hmm.
We discharge them to go do your thing. Whatever. We also tell them that the program we have is 100% effective if you do what you're told. So they never have to take any responsibility for a treatment failure.
Wow.
And everybody fails. Everybody. I mean, there was a group in Albuquerque who was part of a large study, but they studied their particular cohort for 10 years. The percentage of people who stayed sober and continuously for 10 years, 6%.
6%?
Mm-hmm. Now that doesn't mean that they weren't, that wasn't their outcome, you see. But if that's how you measured outcome, did they ever relapse?
Yeah.
Did they ever have a recurrence? We don't use the word relapse. We use the word recurrence. Mm-hmm. So if somebody has had a recurrence, if you consider that a treatment failure, they have a 94% failure rate.
It just sets them up for failure from the beginning.
Right, it does, and then they get blamed for it. Mm-hmm. Oh, it always works. So you weren't working your program.
Yeah, I've heard you say we're blaming the person for failing treatment as opposed to the treatment for failing the person.
That's exactly what we're doing. And so, so here's what we do. So the best way to think about us is we're a mental health clinic that also treats addiction. It's really that simple. And it's just that other doctors just aren't ever trained in this. They aren't trained in how to treat addiction medically. Can
you say a little bit more there? Because I think a lot of people don't understand. Physicians don't really spend time in addiction education when they go to medical school. Is that right?
Well, it's actually more when they go to, when they are in residency. That's where they really learn the trade.
Okay.
And so they watch their models, the resident, the staff. How do they interact with people with addictions? And the fact is they don't know anything about it. Mm-hmm. They don't know how to treat it. It's a mystery to them. They send them off to some sort of a rehab. They don't know what goes on there. They don't care. And doctors will never pay a penalty for ignoring addiction.
Wow.
They'll never pay a penalty for it. They're not required to. Psychiatrists aren't required to. Now, how would you like it if you went to a psychiatrist who said, I don't treat depression? It doesn't make any sense, right?
Yeah.
Well, it makes about as much sense as I don't treat addiction. I don't know anything about it. So what we've done is we have developed a model of outpatient specialty addiction treatment. And that sits between primary care on the one hand and the hospital on the other. And actually on the more intensive, like a day treatment program, those are common in psychiatry. They're also, common in substance use, but they're not, most of them really don't do a good job of integrating mental health at all. But if you thought about intensive outpatient program that also address substance use, so that's the continuum of care. It's primary care, specialty care, and then intensive outpatient care, and then the hospital. Now people say, what about residential treatment? Well, there's no such thing as residential treatment. Residential treatment is an intensive outpatient program in a house. That's all it is. Because staying together in the same house offers no outcome differential. Okay? So what we choose to do is we separate the need for structured housing on the one hand and the need for treatment on the other. Because some people really need a lot of structured housing, but not much treatment. Other people need a lot of treatment, but they can come from home. So it varies a lot. And so it works much better if you can vary the two independently.
Makes sense.
So anyway, so that's what we've done. So this ought to be part of the continuum of care in every system in the country, but it's not. And so ultimately, our goal is to mainstream addiction treatment. And most addiction treatment can and should be done in primary care for alcohol and opioids in particular. Almost all of it can be done there. Some people will need specialty care for a while, and then they can go back and they have continuing follow-up in primary care. Some people are more complicated and they require ongoing care with a specialist. So it's like the continuum of care in healthcare in general. So people are very fond of models in this field, as you probably are aware. So people ask me what my model is, and I say, well, it's healthcare. It is. So it's a funny thing, because when I say these things, people go, well, duh, right? But for some reason, the myths of rehab, the AA myths of rehab, are so pervasive in this culture that people believe them and they don't even know how they got those ideas. One of them is that the families should be punishing and rejecting when someone's drinking. So we teach people the opposite, because punishing and rejection doesn't do anything for anybody except make you feel bad. So we use well, first of all, let me say, on the first visit, all of our patients with drinking problems get this.
Oh, yeah.
Rethinking drinking. This is something that was developed by a medical writer and myself at NIAAA. It's still available. It's free. It's on the line. It's online at rethinkingdrinking.niaaa.nih.gov. But if you just Google rethinking drinking, it'll come right up. Okay?
Perfect. Okay.
This is wonderful. It's a wonderful resource for children. It's a wonderful resource for heavy drinkers. They love this thing. Not judgmental at all. And it's a little pamphlet. So for families, we use this as a text.
Oh yeah, I'm aware of that book.
Yeah, it's a great book. Developed by the Center on Motivation and Change in New York City. Jeff Foote and Carrie Wilkins are the founders of that.
And it's for family support.
Yes, well, it's for it's for the support of the family. We don't define the family in terms of the addiction. We don't define the individual in terms of the addiction. We say you're a person who has an alcohol use disorder, who has an opioid use disorder.
You're not an alcoholic.
No,
Yeah.
not an alcoholic. That's really a big thing, because in the 12-step model, everything is defined that way.
Yeah.
20 years, you can be sober 20 years, you have a bad day, somebody will inevitably say, oh, you're having a dry drunk. What?
And still identifying as an alcoholic 20 years later as well.
So there's no, yeah, in that world, there's no use to have a problem. But in the real world, that's how it is for most people who develop problems. So the study I was referring to was from this landmark epidemiological study called NESARC.
Okay.
And they found about a third of people were early onset heavy drinkers. Most of them before the age of 25, almost all. The peak prevalence for alcohol use disorder is between 18 and 20.
18 to 20.
Yes. Yeah.
What?
What? Exactly. And then it drops. So by 25-50% of those people are well, and by 30-75% are well.
Wow.
Now that leaves 25% that aren't, but we'll get to that. So, and then about 30% are kind of chronic, ongoing, severe problems, multiple problems, physical problems, mental health problems, in and out of hospitals, rehabs, and so forth. And 40% are what I would call variable onset. It can occur almost any time in life, usually in midlife, but it can also occur in late life. These are people, generally speaking, who have some kind of a family history. It's not like a multi-generational, everybody has it, the chronic people, but these are folks who maybe they have a grandfather with alcohol addiction, or they have an uncle, or one of their parents. And that's important because it's necessary to develop tolerance. If you don't have a family history, you can't develop tolerance.
Really? So that does play a role.
Yeah. Oh, yeah. It's genetically determined.
Okay.
It's also genetically determined whether you like how you feel when you drink.
Wow.
And also the adverse effects, whether you get sick when you drink or whether you can drink with impunity.
So I talk to a lot of people who say their first drink, they just like loved it and they knew that was like the magic potion for them.
Right. Those are people with a high genetic loading.
Okay.
Right. And so, it really, and here's the interesting thing is that in that group of people, they get stimulated rather than sleepy when they first start drinking.
That's so interesting.
So those four traits are you almost always present in people with moderate and more severe alcohol dependence.
What are the 4 traits again?
You like how you feel when you drink. You can develop tolerance quite rapidly, and a high tolerance. You are relatively not vulnerable to adverse effects like hangover or puking or whatever. And you get stimulated rather than sleepy when you first start to drink. And there are various penetrations here. So because this is a multigenic disease, polygenic. So and so there's all these different iterations. So some people will have probably the most common pattern for the moderate person is 8 to 12 drinks a day. Okay. People without any genetic loading have a really hard time getting past 5. You have the 8 to 10 folks, and then the more severe are 16 and 20 and above. So it's really interesting that way. So what we do is people come in, they see a therapist, then they see a psychiatrist. We come up with a treatment plan. We implement, we best guess scenario, we implement it, and then we follow up. So they'll follow up with a counselor, for a therapist for weekly, usually for a few months. And they'll learn CBT-oriented recovery skills, but also their other disorders will be treated. So all of our therapists are master's level. They're dual trained in substance use and in mental health.
Wow.
Because most people will have a mental health problem. Anxiety is very common. Depression and other mood disorders. PTSD, phobias, like social phobia. What else is common? I think those are the most common. Mm-hmm. And so, but those have to be treated, and you can't wait. You can't wait until they stop drinking for a year, because otherwise they can't stop drinking.
Yeah.
You have to remove the barrier initially. So we'll use medications. We use all the anti-relapse medications that have evidence. Mm-hmm. And there are about 4 or 5 of them, depending on how you look at it. And we use other medications for whatever they have. Plus, we do psychotherapy. So, they see a doctor about once a month, typically, for the better part of a year. And then, depending on how things are going, then it may, probably drop back to every 3 months. But our length of engagement here, our average length of engagement is 2 years. And I tell everybody when I first start, I say, take these medicines for at least a year. This is for alcohol. And then we'll talk about it, whether you want to continue or not. Because it takes at least a year for not drinking to start to feel normal. You have to go through the holidays, the seasons, you have to go to a wedding, you have to have a fight with your spouse, all these ups and downs, right? And they're all triggers. And you have to learn how to manage life without alcohol. For opiate addiction, we use buprenorphine. And we don't use injectable naltrexone unless somebody is very highly motivated for it. I don't think it works very well. But you really don't stand a chance if you're not taking Suboxone or one of its variants. And so that's the first. And I say, plan on taking this medication for at least 2 years.
No.
Because that's how long it'll take you to dig out of the hole you're in. And usually it takes longer than that. But so those are our 2 big ones. Meth has come up a bit. I use stimulants. It's very controversial, but they work. A lot of times people can't stop using meth if you don't put them on stimulants. They all have ADHD.
Wow.
Oh, that's the other big one is ADHD. I'm a huge proponent that you treat the ADHD in someone who's got an addiction.
ADHD and addiction are linked?
Yeah, yes, they are.
What?
Yes.
I had no idea about that.
Yeah. There's a great deal of comorbidity.
Huh.
Yeah. And most people, the received wisdom is, well, you don't treat that because of cross addiction, right? They're going to get addicted to it. I've had one person get addicted to it.
So would you mind if we spoke about cross addiction for a second? Because I thought that was a thing. Like this is news to me.
Yeah, right. Well, so this came from NESARC, the same study. So people looked at the group who were in recovery from substance use disorder number 1. And they looked at them 3 years later. 10% had developed another addiction.
And are we talking addictions to substances or food or sex or things? All of those? Okay.
All of the above.
Okay.
So, so you have to think about how addiction occurs. The primary disorder with addiction is heavy use. And that's genetically determined. It's specific, especially for opioids and for alcohol. And they're the same for each one. But obviously they're different because most people with alcohol use disorder don't really like opioids and vice versa. Right? Yeah. But if you ask some future opioid addict how they felt when they had their first exposure to opioids, they'll say, "I loved it."
Oh.
I loved it. I finally felt normal. That's an interesting clue. So the thing is so those 4 traits that I mentioned make it very easy to drink or to use opioids a lot, repeatedly for a long period of time. Addiction develops as a secondary process, resulting from from the exposure of the brain to high levels of either of these drugs. And the first thing that develops, and the most universal and central phenomenon of addiction, is impaired control once you start. I call it the water slide. Before you get into a water slide, you might say, I'm going to stop 15 feet into this water slide.
Good luck.
And then you change your mind, right? But there's a second piece, which is why you come up with the rationalizations you do. So the second part is that what starts as a voluntary conscious behavior, taking a drink, becomes unconscious and automatic. And that's a process. And the process doesn't start with drinking or using. It starts with anticipation of drinking or using. And we love anticipation.
We do.
It's always better than the real thing. It's titillating, it's exciting, it's rewarding. We don't want that to stop. And then it's seductive. And as that process continues, we start saying, well, I've been sober now, 2 weeks. I should be able to reset things. And no, but people have to learn that on their own. They have to try this all out on their own. You can't, people don't stop because somebody else tells them to stop, unless it's a judge.
Yeah.
That actually works quite well. But but people stop mainly because they've actually tried it out over and over again and found that the same thing happened.
Yeah.
No matter what they did. And the thing is, we go through that process with people over time. That's what takes the time.
Yeah.
So somebody will get sober for the first time in 25 years. And after a few months, they're feeling great. They've never felt so great. They're in shape, they've lost weight, blah, 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 blah. And then they'll think, well, maybe now I can drink. Maybe now I'll be able to control it. No, damn it, it didn't work either. And not only that, but now I've got a contrast to compare it with. And I really felt like shit. And now I remember feeling like shit all the time, but I thought it was normal.
Mm.
So anyway, and we use a workbook, by the way. This is the workbook here.
Okay.
It's called the Addiction Recovery Skills Workbook, and it's by Suzette Glassner Edwards. And it's not revolutionary, but it is revolutionary just because it's so much common sense in there. And we do a lot of CBT, we do a lot of EMDR, cognitive processing therapy for PTSD,
Wow.
CBT for anxiety and depression. We do, a whole variety of psychotherapies.
Wow.
So, and we do it for about, well, it depends on the place, about a 10th or 20th of what it would cost you for a month in a rehab.
Wow.
Yeah. And that's for a year of integrated treatment.
Wow.
So.
Considering how much we can spend on the substances and how,
Yeah, that's right. Yeah, people will say, I can't afford this. I say, how much were you spending on X?
Yeah.
Oh, I hadn't thought about it that way.
Yeah.
That's amusing.
So what is recovery then? Because I know with the AA model, it's been about abstinence, and as soon as you relapse, you're back to square one. But to you, what is recovery?
So in the 12-step model, abstinence is not recovery.
Okay.
It's a necessary but not sufficient condition for recovery. Recovery is being abstinent and developing your character.
Okay.
A good person, basically.
Okay.
Being a mature person. Now, I don't even talk about, well, what I talk about with recovery is, it's basically the absence of, I really talk about remission,
Mm-hmm.
right? Which is the absence of a disease that was once there.
Yeah.
And there's both abstinent and non-abstinent remission.
I see.
So it turns out that there's about half of the people in the mild end of the spectrum, 5 or fewer of the DSM-5 symptoms, are able to achieve and maintain stable, low-risk drinking. But about half of them will eventually give up and decide that abstinence is easier than controlled drinking, because you're not constantly tempting yourself.
Yeah.
Having to, So, about half of those will either decide they have to abstain because they either keep going off the rails, or because it's just too much work.
Yeah.
For what they get out of it. Here's the thing: low risk drinking. With low risk drinking, you don't get intoxicated. So if what you're really wanting is the drug effect, not a beverage, but a drug effect, you're not going to want to have one drink or 2 drinks. That's torture.
Mm-hmm.
So that's really the rub with addiction is you get really hooked on intoxication.
Yeah.
You're using a drug. You're using alcohol as a drug. You're going for a blood alcohol level. That's what you're going for.
Yeah.
Not the taste and not the blah, blah, blah.
It's interesting to hear you say that, because I've heard of people on naltrexone treatment who will see the results drinking on naltrexone to improve and reduce their alcohol, but then they might drink beyond it or kind of notice that inclination to stop but keep drinking. And it sounds like potentially it could be because they're drinking for the reasons you say.
Yeah, but they'll get drunk, but they won't enjoy it.
Yeah.
So, naltrexone works really quite well in our population, which is, Northern European, Scandinavian.
That's what's been tested? Has it been tested in other?
It works the best in that group. That's what we know for sure. And most of the work has been done with that group. It may not work very well in especially people of African American descent.
Huh.
So I always have them test it out. Take naltrexone and then take a drink and see if it feels any different.
Yeah.
Because there's no use taking it if it doesn't work.
Yeah.
Listen, I've got to go.
Yeah. Thank you. It's been an hour already. Thank you so much for your time today. I really enjoyed speaking with you.
Good talking to you too.